And thanks everyone for joining this session today. It's a split session. In the first part, I'll be talking about preventing adverse childhood experiences, and then colleagues from CDC will talk about e-cigarettes and vaping in the second part of the session. And my name is Chris Jones. I serve as the Deputy Director in the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. I do not have any conflicts of interest to disclose. And at the Injury Center, as you heard in the town hall and the CDC 101 in various places probably throughout the week, in the Injury Center, we have three strategic priorities: adverse childhood experiences, opioid overdose, and suicide. And these are all interrelated and urgent public health challenges that have consequences for all of us as individuals, families, and communities across the lifespan. But the good news is that they are preventable, and we can adopt a coordinated, comprehensive approach that can prevent harms that are occurring today while also preventing harms in the future. So for today's talk, I'll talk about the relationship between adverse childhood experiences, or ACEs, and leading causes of adult morbidity and mortality, describe the connection between ACEs and substance use, discuss evidence-based ACEs prevention strategies, and then discuss how coalitions might think about integrating some of the ACEs prevention work into their existing strategic framework. And I think importantly, as we're going through the talk today, really thinking about what are those pieces where you're already doing something, but you may not have even labeled it as ACEs prevention. What are those things where there might be new partners to bring into the fold that could address some of the issues around upstream ACEs prevention or secondary prevention of ACEs. So hopefully you'll see a bit of your ongoing work throughout the presentation, as well as some new opportunities to think about substance use prevention in the context of ACEs prevention. So what are ACEs? I think is an important first question, so we're all on the same page. And ACEs are experiences that can be traumatic to children and youth, typically defined as during the first 18 years of life, such as experiencing violence or other types of emotionally disturbing exposures in the home or community. In the mid-1990s, CDC partnered with Kaiser to do a study looking at specific events that were termed adverse childhood experiences. And those are the typical ways that people look at ACEs or count ACEs. And so those things are physical abuse, emotional abuse, sexual abuse, physical or emotional neglect, and then challenges in the household: mental illness, incarcerated relative, substance use in the home, intimate partner violence or domestic violence, and divorce. And those were sort of the traditionally defined ACEs. And that initial study was published in 1998 based on those particular outcomes, and looking at the connection between those outcomes and subsequent health outcomes or social outcomes. As time has evolved, we have broadened what we think about ACEs, and there are a variety of different experiences that might occur to an individual or in an individual's environment that produces a similar effect in the body physiologically that would result from the original defined ACEs. So those are things like bullying, teen dating violence, peer-to-peer violence, witnessing violence in the community or at school, not just in the home, homelessness, death of a parent. Those are other traumatic, potentially traumatic events in childhood. And so I think as we talk about ACEs, it's important to think broadly about the types of events that might happen in childhood that could affect the safe, stable, nurturing relationships of an individual. We also have a greater appreciation now beyond just the typical ACEs that are represented here as sort of the branches and leaves of the tree, but a greater appreciation of sort of the underlying roots that are contributing or exacerbating, perpetuating ACEs and the impacts of ACEs on health, social and economic outcomes. So things like poverty, discrimination, community disruption, violence in the community, housing insecurity, lack of economic opportunities, systemic racism, these other sort of social determinants of health clearly play a role in the impacts of ACEs. And so as we think about prevention, it's important to not only think about those originally defined ACEs, but the context in which individuals, families, and communities are operating. And we know from over 2 decades of research that ACEs have been associated with more than 40 different health outcomes, including things in the injury space like traumatic brain injury, mental health, so depression, anxiety, suicide, maternal health, unintended pregnancy, complicated pregnancies, fetal death, infectious disease, so sexually transmitted infections, HIV, chronic disease, things like cancer, diabetes, risk behaviors. So certainly this is very relevant to coalitions, alcohol, tobacco, substance use, and opportunity. So graduation rates, high school graduation rates, keeping a job, having sufficient income. And I call out specifically here, and I'll certainly talk more in depth later on about the relationship between ACEs and substance use. But certainly this is just one example of the relationship between the number of ACEs and ever having a drug problem or substance use problem. And you can see here that there is sort of a graded response. As you are exposed to more ACEs, you are more likely to have a substance use problem. And that sort of graded response is fairly consistent across all of the outcomes here, that as you experience more ACEs, you are more likely to have these sort of negative health consequences over the lifespan. We also know that individuals who have experienced ACEs have a reduced life expectancy. In particular, individuals who have accumulated a large number of ACEs. This particular analysis looks at people with 6 or more ACEs died nearly 20 years earlier on average than those who had not experienced ACEs. And again, that's not a surprise if you think about increased risk for suicide, increased risk for substance use, increased risk for cardiovascular disease, diabetes, other leading causes of death. It's not surprising that these individuals would die earlier than individuals who may not have those conditions or may be at lower risk for having those conditions. But certainly a large impact at a population level due to ACE exposure. We also know that there is substantial economic cost. Colleagues here in the Injury Center conducted a study a couple of years ago where they looked specifically at the cost of child maltreatment or child abuse and neglect, which is very much associated with ACEs. It actually covers 5 of 10 ACEs. And what they found is that the economic impacts are over $400 billion a year. And that is a fairly conservative estimate based on the way that this study was done. So no doubt, if you add in other types of ACEs, you're well into the hundreds of billions of dollars, if not trillions of dollars, for economic impact. So not only does this have impacts to individuals and families, but a large impact to society from criminal justice, child welfare, education, healthcare cost, as well as other social costs. So certainly when we think about this in public health terms, it is absolutely a very pressing issue that needs to be addressed. And we also know that ACEs are prevalent in society. Last November, CDC put out a Vital Signs, which is sort of a monthly showcase of an important public health topic. And the November Vital Signs from last year focused on adverse childhood experiences. And we looked at data across about 25 states from the behavioral risk factor surveillance system to estimate among adults how many individuals had experienced 1 or more ACEs. And what you see in the top left-hand box here is that overall, about 61% of the adults in the survey had experienced at least 1 ACE. So the majority of individuals, adults in these states, had experienced more than 1 ACE. And you can see here that about a quarter had experienced 1 ACE, and then about a little over 20%, 2 to 3 ACEs, and almost 16%, 4 or more ACEs. And I think it's the 4 or more in particular that was, I think, particularly relevant for me, and when we were doing this analysis, is to show that, again, this is prevalent in our communities. So 15.6% translates to 1 in 6 adults had experienced 4 or more types of ACEs. And we know consistently through the literature that experiencing 4 or more ACEs, you are at incredibly increased risk for a variety of health outcomes, including a variety of substance use related outcomes. And so it is something that is not happening in the margins of society or on the fringes of society, but it is very much prevalent in our communities and is influencing health in our communities. We also know that 5 of the 10 leading causes of death are associated with ACEs. So again, from a prevention standpoint, there's a lot to be gained if we can reduce ACEs. And as one example, we estimated that preventing ACEs could reduce the number of adults with depression by 44%. Obviously, depression is very much connected into substance use, so you could see that would have spillover impacts for reducing substance use as well, in addition to suicide and other health outcomes. And as we think about youth prevention in particular, and we think about ACEs prevention, it is important to note that ACE exposures start to accumulate very early in life, in particular in the first couple of years of life. And this is data from the National Survey of Child and Adolescent Wellbeing, which looks at a high-risk population, individuals who had contact with the child welfare system. But what they did is they looked at the percent of those individuals in the survey by age group who had experienced ACEs. And you can see here that by the age of between 0 and 2 years old, 38% had experienced 4 or more ACEs. So again, very early in life, there was exposure to adverse events. By the time people were 11 to 17-year-old, which was the top end of the age group in the survey, 68% had experienced ACEs, 4 or more ACEs. And so again, I think it really underscores the importance of one, primary prevention, but can we reduce this before it happens, and the importance of doing it early. And no doubt this is certainly relevant to the work of coalitions who are thinking about, when do people start engaging in substance use? If we start focusing on people as they're getting ready to go to college, that's really too late. And so thinking about ACEs in a similar way, we really need to think about, even in the prenatal period, what are things that we can be doing to reduce risk of ACEs? And then throughout a child's development into adulthood, where are the places that we have opportunities to prevent ACEs before they occur, but also to mitigate once they have occurred, to lessen further accumulation of ACEs or to reduce the harms associated with ACEs. So I've talked a little bit about the epidemiology, how prevalent ACEs are, their impacts on health, on social outcomes, on economics. But I want to now switch to really talking about, okay, so what is it that's happening that helps us understand why ACEs have such a strong link to health and social outcomes. And this is a fairly straightforward schematic that just looks at the lifespan and age and the brain's ability to change in response to experiences. And that is represented by the green line, where you see that certainly at earlier ages, the brain is really a sponge. It is constantly growing and adapting and changing based on the experiences that it is exposed to, whether they be positive or negative. Again, you can see here, even in the 2-year age group here, that's really at the top end of where the brain is forming and is sort of a sponge to external stimuli. And if you think about the survey of kids in the child welfare system, again, 38% between the ages of 0 and 2 had experienced 4 or more ACEs. And you can see that if there are negative stimuli that are coming in, the brain is highly adaptive to those effects. And as people get older, you see that it is less adaptive and it requires much more work to change the brain. And I think there's a good example in the substance use space where we know that if we can slow or prevent the initiation of substance use into, say, the mid-20s, the chances of someone developing a substance use disorder later on is substantially reduced because the brain has had more time to develop. You're not sensitizing a young brain to rewarding effects of substances. And there's sort of a similar approach here. And I use it in my own example. I have a 7-year-old daughter who can rapidly pick up Spanish. It just makes sense to her. In my 40-year-old brain now, I'm really on this top end of the amount of effort it would require me to learn Spanish. I just don't pick it up as quickly. And I think that is another sort of tangible example of how, in particular young ages, are such sponges for information. And that can be both, again, positive and negative. And thinking about specifically what is going on with ACEs, this schematic, I think, does a nice job of putting a framework around early life stress and development of toxic stress and how that impacts the brain. So experiencing stress is certainly a normal part of development. And if you have kids or have been around kids, especially babies, when they need to be changed, when they're hungry, they cry, there's a stress response. And in an environment where it's sort of safe, stable, nurturing environment, you change the baby, you feed the baby stops crying. And that sort of stress environment is the way in the body, there's a signal that says I'm hungry or I'm uncomfortable because I need to be changed. And the body releases a number of chemicals that results in a behavior change. So crying in this example, to bring attention to the caregiver who then addresses the need, and the stress levels go back to normal. When someone is exposed to repeated adverse events or traumatic events in life, the body is trying to respond as it is built to respond by releasing stress hormones. But the problem is in the absence of something that shuts that off. So caring, responsive relationship, getting your needs met, those types of things, the body just continues to ramp up and it becomes this cycle of release of toxic stress hormones like glucocorticoids, norepinephrine, and that plays out in different areas of the brain. And over time, that impacts the structure and function of the brain, the immune system, cardiovascular system, other systems in the body, and you get this accumulating effect of dysregulation in how the brain works. And the brain is typically built to provide feedback mechanisms so that when something gets out of whack, there's another system that turns on that helps to shut that system down. And what you see in a toxic stress environment is that system of feedback is not working. And this schematic is obviously very complex, and I won't go through all of it, but I will point out that there are multiple areas of the brain in which toxic stress has impacts. And again, they all feed on each other. And what you see over time, again, in the absence of protective factors, you have, again, this amplified response to stress, which impacts the reward circuits of the brain. It impacts the processing of emotions, how you're able to cope with stress or emotions. It impacts your executive function, so the prefrontal cortex of your brain, which is already the last thing that develops in really early adulthood. And it affects cognition, decision-making, and then ultimately it affects other organ function as well. So it's really no surprise that if you are being constantly bombarded by stress and you are in sort of a toxic stress environment, that your brain, especially if exposed early in life, is not able to develop in a way that allows you to handle emotions appropriately, to process those emotions, how you respond to rewards, which is, again, very much connected into addiction and substance use. You don't necessarily develop the brain connections around appropriate coping strategies. And then again, executive functioning, which is the part of your brain that says, this is a risky behavior. This is not a risky behavior. I shouldn't do this because I know if I do this, X, Y, or Z might happen. If that area of the brain is not functioning optimally, it is much easier to then devalue the risk of things like substance use or other high-risk behaviors. And so that's often how it plays out. But fundamentally, underneath this is complex science that really is driven by the release of various stress hormones and the accumulation of that in the brain and body over time. I also think it's important to point out that different types of traumatic events or adverse childhood experiences affect areas of the brain in different ways. And so as we think about treatment or prevention, recognizing that someone who has experienced emotional maltreatment or physical neglect might respond differently to certain stimuli than someone who has experienced sexual abuse. So in some cases, people who've experienced ACEs may demonstrate more aggressive or violent behaviors or more risk-taking behaviors that are sort of externally manifesting, whereas someone who maybe has experienced sexual abuse, it might be more internalizing behaviors, withdrawn, depression. They may gravitate more to certain substances where we see a connection between opioids and sexual abuse. And part of that is in what is the reward for opioids and how does that feel to someone who has experienced sexual abuse versus other types of abuse. There are some ACEs and there are some consistencies across ACEs that impact various areas of the brain, like the prefrontal cortex or the executive functioning aspects of the brain. And this is obviously a very complex and continually evolving area of science. But again, I think it is important that with brain imaging and other studies, we can start to better understand and start to tailor efforts to address the particular types of ACEs that individuals have experienced. And putting this all together, I think this is important as we think about prevention in particular around how do ACEs play out through the lifespan. So it's not that somebody just starts at having heart disease, but there is this long pathway that gets to that point. And along that pathway, there are many opportunities for prevention. So initially, someone experiences an adverse childhood experience. They have, through a toxic stress response, disruption in their neurodevelopment. So how they, again, process emotions, how they process reward, what is reward for them. So you start to see that play out in social, emotional, and cognitive impairment. So they are not able to handle stress or conflict in a way that someone who had a stable, nurturing environment or was not exposed to ACEs is able to do. And so they develop coping mechanisms that are often associated with health risks, such as substance use or internalizing symptoms, those types of things. And then you start to see that play out. So again, we know that unhealthy substance use is associated with many other health outcomes. So you start to see that play out for both impacts on health, as well as if you have not been able to focus or be successful in school because of a chaotic household or because of engagement in health risk behaviors, you start to see that you fall behind, and that sort of has this accumulating effect. And ultimately, this all plays out in disease, disability, and social problems, and then early death. But again, there is science along the way that helps us understand how each of these things play out, and there are prevention opportunities across the lifespan to address these issues. So it's not so much important that you understand all of the pathways that are happening in the brain, but to understand that there is a science underpinning how a traumatic event or series of traumatic events in childhood can influence health throughout the lifespan. And what does this look like in kids? How does this display out? So again, you have emotional dysregulation, so that kids may not be able to process or regulate emotions in the same way. And so sometimes that might be kids are acting more withdrawn, or it could be that kids are more explosive or aggressive because they're getting these stimuli and emotions, and relationships are happening in the school or home environment, and they don't know how to process them. So they sort of come out in different ways. Similarly, because of impacts on the reward circuits in the brain, kids may not respond in the same way. So a teacher who is praising kids for doing good, and that might be a motivator for a child who had not experienced adverse childhood experiences to continue to do something. But in a kid who has diminished social reward, they may not respond to that, what would otherwise be seen as an incentive. Similarly, difficulty with executive functioning. Again, this gets to the prefrontal cortex. And this is sort of the ability to be organized, stay on task. And clearly from a, educational attainment perspective, kids who are not able to complete assignments, don't understand assignments, are not able to pay attention in the classroom, they may fall behind, again, which sets them up in the future to not be as successful. And then again, this issue of sort of amplified response. So if you think about any person that hasn't been exposed to ACEs, again, some traumatic event may happen. They have this stress response, but they have resilience to sort of get back to a baseline level. But for kids, in particular kids who've experienced many ACEs and have experienced those over a period of time, their baseline level is always sort of elevated. And so when they get an external stimuli, a stressful event, they are really sort of revved up and go from 0 to 1,000 very, very quickly. And again, it gets back to being able to process all of that information and connections between various aspects of their brain. And so I think this is important to understand, because as we think about prevention, we want to look at what are the things that can help mitigate these effects. So as an example, if kids who've experienced ACEs are not able to optimally process conflict, problem-solving skills, well, prevention programs can focus on helping them with doing that. So there are sort of tangible intervention points that address the underlying science and behavioral manifestations of exposure to ACEs. So what about ACEs and substance use? And I think this is something that continues to grow over time as we really think about the worsening overdose crisis in the US, and we put a lot of money into the stream to expand access to treatment and recovery support services, and those things are all critical. But I think for all of us, there is increased hunger to think about what's the long-run strategy. We have to treat people who have substance use disorders and get them successfully into long-term recovery, but we also need to stop introducing additional people into the stream of risk for developing substance use disorders. And I think looking at the connection between ACEs and substance use is a really potent place for prevention. These are data from the initial ACEs study, which I mentioned, that CDC and Kaiser conducted in the 1990s. And you can see here across 4 different outcomes: current smoking, alcohol use disorder, ever use illicit drugs, ever injected drugs. There is a consistent and strong relationship between the number of ACEs individuals are exposed to and the risk for those particular outcomes. And so while we definitely see that individuals with more ACEs have higher risk, it's important to note that even those with 1 or 2 ACEs also have elevated risk. And so we think about this very broadly, that there is a lot of potential for prevention across the spectrum. We don't need to just focus on those at the more extreme end of the spectrum, but even reducing among those who have experienced fewer ACEs has a potential for prevention impact. When we look at various aspects of ACEs and substance use among college students, we find, again, very consistent across different measures of substance use, a significant and strong relationship with ACEs. And you can see here, just looking at the prevalence of ACEs among among college students, you can see here parental substance use. More than 1 in 5 had experienced parental substance use. Exposure to parental intimate partner violence, almost 10%, 16% sexual abuse, physical abuse, 14% verbal abuse, 25%. And again, almost 1 in 4 had experienced 2 or more ACEs. So again, it varies across the different types of ACEs, but again, in sort of an overall sample of college students, you can see that ACEs are fairly common. And when they look at who accounts for the use of various substances, and this is the top gray and white figure here, you can see that, again, across alcohol, tobacco, marijuana, illicit drug, prescription drug misuse, polysubstance use, the majority of people who report engaging in that behavior had exposure to ACEs. And you can see that it grows as you get into things like past 30-day illicit drug use, where nearly 75% had been exposed to ACEs. And that's ACEs overall. When you start to look at different types of ACEs and impacts or risk on marijuana, tobacco, and alcohol use, again, you see across the various types of ACEs, there is still a significant relationship between exposure to parental intimate partner violence or parental substance use and risk for past 30-day use of those substances. Same for prescription and illicit drug use as well. So whether you're looking at ACEs together or individual ACEs, there is a clear connection between ACEs and substance use. Now, of course, when we think about overdose deaths and opioids being involved in the vast majority of those overdose, and often prescription opioids being the entryway into opioid use disorder, preventing the misuse of prescription opioids is certainly a key part of the opioid overdose reduction strategy. So CDC colleagues work with state colleagues to look at the connection between ACEs and prescription opioid misuse in 2 samples of the Youth Risk Behavior Survey, which is high school students looking at Montana and Florida. And you can see here generally consistent findings that compared to people who had not experienced ACEs, which is the 0 group in both of these figures or both of these tables, people who had experienced ACEs had increased odds of reporting misuse of prescription opioids. And you can see that the odds are even higher for people with 3 or more ACEs. And again, this is really among the population where people are first starting to engage in misuse of prescription opioids. So again, alcohol, tobacco, marijuana, prescription opioids, illicit drugs, there's consistency in the relationship between ACEs and increased risk for engaging in those substances. We're also very interested, certainly at CDC, and I imagine many of you in your communities, around the resurgence of stimulants, in particular concerns around resurgent methamphetamine, increased cocaine availability, and harms related to methamphetamine and cocaine use. We analyzed data from a large national survey to look at the connection between ACEs and stimulant use disorder. Not all of the findings are here on this slide, but a couple of the findings are, again, consistent with the survey work among college students. Among people who reported past year amphetamine use, past year amphetamine use disorder, past year cocaine use, and past year cocaine use disorder, the vast majority of those individuals had experienced at least one ACE. And you can see here the breakdown. This is particularly striking among individuals who have a use disorder. So again, you see almost a third of people who have, or actually a third of people who have either a cocaine use disorder or amphetamine use disorder had experienced 4 or more ACEs, compared to about 17% had experienced no ACEs. So again, as we think about prevention and these emerging issues, ACEs are a important place to be thinking about our prevention work. We also looked at the mean number of ACEs and at what age did people first engage in stimulant use. So both for amphetamine type stimulants as well as cocaine, we see that people who had higher number of ACEs, higher mean number of ACEs, tended to engage in substance use or initiation of stimulant use much earlier than people who had fewer or no ACEs. And it's particularly striking, you can see here, among people who first used stimulants at the age of 14 or younger, their mean number of ACEs was almost 3 for amphetamine type stimulants and a little over 3 for cocaine. And you can see the pattern is fairly consistent. And so again, as we think about, what are opportunities for prevention of initiation of substance use and where do we target those in the age range, kids who have experienced larger number of ACEs are initiating at a younger age. And so it is important that we are thinking about prevention throughout the lifespan, in particular because of what we know about ACEs and how they accumulate early. This is another study that looked at individuals who are coming into treatment who were using methamphetamine, and this is just broken down by males and females, by different types of early adversity. Again, high prevalence among this population of various types of emotional abuse, sexual abuse, physical abuse, felt unsafe or dangerous, food insecurity, housing insecurity. You can see there are some differences among males and females, but overall, this is a population of individuals who have experienced lots of trauma. And so again, that presents opportunities for prevention, also opportunities as we think about trauma-informed care for treatment. And overall, when we look at substance use risk factors, it really overlays with risk factors and opportunities for prevention with ACEs. So at an individual level, from a substance use risk perspective, there are genetic factors that are at play for substance use risk. Initiating substance use early, if you have low risk perception of substance use or your peers who use substances, if you are experiencing emotional distress or aggressiveness that starts early and is persistent, again, that is a sort of hallmark sign of experiencing ACEs for some individuals, or psychiatric disorders. Those are all individual level risk factors. From a family perspective, so substance use in the family, again, that's a defined ACE. Family conflict, abuse, or neglect, again, that's an ACE. Parents who favorably view or approve substance use, lack of family connectedness. Again, all these are very much connected into ACEs and the family dynamic. At the school level, so poor academic performance, again, an outcome of being exposed to early adversity. Students who don't view school as rewarding or meaningful, or lack of commitment to school. Perception that use of drugs is high among classmates, and poor control over drug consumption at school. And then from a community perspective, lower socioeconomic status or underlying economic stressors in communities, availability and cost of drugs and alcohol, community norms favorable toward alcohol and drug use and lack of community connectedness and supports. And I think, in addition to ACEs prevention, this also layers on nicely to the work and the framework that coalitions implement to address at multiple levels, the individual, family, community level, risk factors for substance use. And so when we look at protective factors, again, these are really just the flip side of risk factors. So having resilience, self-efficacy, some aspects of spirituality, interpersonal skills, so knowing how to handle and process conflict, emotions, getting along with others, how to engage socially, treatment for underlying psychiatric disorders. Those are all individual level protective factors. At the family, community, school level, again, sort of connectedness, attachment to family, school, and community, meaningful involvement in activities in your family, school, or community, safe, stable, and nurturing relationships, which is really fundamental to ACEs prevention, having positive behavior, recognizing as a norm, norms in the family, school, and community that drug use, violence are not acceptable, that seeking help is acceptable behavior, and then opportunity for fulfilling extracurricular activities. And so I think this really lays out the framework and roadmap for ACEs prevention, which obviously has an extension into substance use prevention. So why is ACEs prevention important? As I mentioned in our vital signs that was released in November, part of our analysis was to look at what could we accomplish if we prevented ACEs. And we looked at a variety of health conditions, health risk behaviors, and socioeconomic challenges. I already mentioned one of these earlier. We could, if we could prevent ACEs, we could reduce the number of people who have depressive disorder by 44%. That was our largest effect size that we found in the study. That's not a surprise given the connection between ACEs and emotional health. But we also saw for chronic diseases like chronic obstructive pulmonary disease, a 27% reduction, coronary heart disease, 13% reduction, cancer, 6%, diabetes, 6%, overweight or obesity, 2%. So even among the leading causes of death, or things that are causing lots of economic and social costs in communities, advancing prevention for ACEs has a substantial payoff for public health or chronic conditions. We also looked at health risk behaviors. So a 33% reduction in current smoking, a 24% reduction in heavy drinking. Again, significant opportunities for reducing those risk behaviors, which are very much connected into many other health outcomes. And then even among socioeconomic challenges, you could reduce unemployment by 15%, insurance coverage by 4%, less than a high school education by 5%. Again, if you think back to our underlying scientific understanding of ACEs, this makes perfect sense that there is this real opportunity for prevention. And as we convert those percents into numbers of people, that 44% reduction in depression translates to 21 million fewer cases of depression, 1.9 million fewer cases of heart disease, and 2.5 million fewer people who are overweight or obese. So again, really large payoffs for public health. And as we think about prevention at CDC, and I think this is also very consistent with the coalition model, is that there is a pyramid in public health that looks at sort of underlying socioeconomic factors, the environment, sort of long-lasting protective interventions that really have an increasing impact on population public health. And as we get into things like clinical interventions, individual counseling, that's really where we focus on impact for individuals. But from a collective perspective, they have less impact on public health. And so it is really in the bottom portion of the pyramid that we focus the majority of our ACEs prevention work. And again, I think that's also very consistent with the framework for what coalitions are doing and thinking about policies in the environment and messaging and norms aspects of substance use prevention. And at CDC, in conjunction with our November vital signs, we also put together a prevention resource document that essentially synthesized and assessed what we know about the evidence base for preventing adverse childhood experiences and put it into a relatively short document that really is sort of a roadmap for ACEs prevention. And it's framed in a way to look at preventing ACEs before they happen, identify those that have occurred, and respond in trauma-informed ways. And it focuses on 6 areas. And again, these move from sort of the community, society perspective to sort of individual level interventions. So I'll talk more about each of these in a minute, but just to cover the 6, strengthening economic supports for families, promoting social norms that protect against violence and adversity, ensuring a strong start for children, teaching skills, connecting youth to caring adults, and intervening to lessen immediate and long-term harms. And that's sort of the 6 overarching approaches. And within each of those, there are specific policies, programs, or practices that are highlighted as opportunities for action to advance the goal of, for example, strengthening economic supports to families. So we know that when there are economic stressors in the household, job insecurity, concerns around, where are we going to get our next meal from, irregular work hours, all of those things contribute to, or can contribute to, an environment in the home that is not stable, that is not getting everyone's needs met. And so there are policies like the Earned Income Tax Credit or child tax credits that are, at a federal, state level, that have been rigorously studied to show benefits in reducing various aspects of adverse childhood experiences or risk factors for adverse childhood experiences. Things like child care subsidies, flexible and consistent work schedules, family-friendly policies like paid family leave, again, all have evidence from research that support that they have impacts on things like child abuse and neglect or maternal depression or household stress. Again, these are sort of underlying contributors to an environment where adversity and adverse childhood experiences can occur. So these are sort of bigger P policies, but certainly supporting these types of things and thinking about from a coalition's perspective, you have a great setup because you have essentially the pillars of your community and the sectors are there. And so thinking about how do we reduce stress that's going on in households to help stabilize and have a more predictable, safe, stable household, these are some policies that could be considered for that. And I think, in the context of COVID-19, many of us have probably experienced this more so than we ever have before, of just uncertainty and understanding how that can play out when your normal routine is disrupted. And so thinking about, how do we advance these policies in the context of substance use prevention and ACEs prevention? I think there's a lot of opportunity there, and certainly science to support the benefits of these efforts. The second area is promoting social norms that protect against violence and adversity. So again, this is an opportunity to sort of set the tone within communities or within different subgroups within communities about what are our social norms in our community, and public education campaigns are one way to do that. And so thinking about campaigns that really move from sort of individual responsibility to community responsibility for the health and well-being of children. Supporting parents in positive parenting. What are sort of the expectations for positive parenting? Norms around gender, masculinity, and violence are opportunities to reduce adversity in communities. Reducing stigma related to help seeking. So we continue to see in the substance use space, despite lots of money going to expand access to treatment, there is pervasive stigma among community members, among healthcare providers, around people who use substances or have substance use disorders. And so really changing the community conversation around help seeking or help seeking for parenting and positive parenting. Becoming a new parent is really tough. I from my personal experience, there were just so many unexpecteds and I was sleep deprived, and I had means and resources to be able to shore up the gaps that I experienced. But for some individuals, there could be shame in wanting to ask for help of how do I do this? How do I communicate? What should I expect? And so, again, from a collective community perspective, thinking about help seeking. Same for mental health or suicide. Making it the norm that these are challenges that we are all at risk for facing to more or less degrees. But the sort of brave thing and the norm for the community should be seeking help. And then efforts around connectedness and building resiliency. Again, I think COVID-19 really underscores the importance of connectedness and thinking about sometimes we may not be able to do that in our traditional ways of gathering in a place, but how do we do it in a virtual environment? And I think we really have a greater appreciation of that sort of social connectedness and the importance it has for our own health and wellness. Looking at bystander approaches, men and boys as allies in prevention. Again, there are various research-tested strategies or interventions that can be used here that promote social norms against violence, or that violence is not acceptable, or that there are things that each of us can do to reduce the perpetration of violence or scenarios where violence or adversity might be likely to occur. Moving into ensuring a strong start for children, again, if you look back on the epidemiology of ACEs, you really understand that this has to start even before kids are born. In the prenatal period, there are opportunities to ensure a strong start for children, and that goes through early ages, preschool, into elementary, middle, and high school. But one of the most powerful programs in this space around early childhood home visitation is the Nurse-Family Partnership. And it has been rigorously studied in randomized controlled trials. And it's a program that essentially you have a nurse who engages with a pregnant woman. Typically, studies have focused on higher risk women or socially disadvantaged women who are pregnant. And in the first 2 years of life, they provide support, tools, and coaching around parenting and positive parenting. And what they found that in this intervention that is, relatively short-term intervention, first 2 years of life, there are these long-lasting protective effects for both the mom who was exposed to the program and the kids whose mother was exposed to the program. And so things like reduced reliance on social welfare, crime, other substance use, other outcomes for the mother, as well as improved high school graduation rates, reduced substance use, crime, recidivism among the kids who were exposed to this intervention. So I think, again, it really underscores the importance of that early few years in life, really setting people up for success. And as we move beyond that early phase, thinking about high quality childcare, which really sets the stage for having sort of a safe, stable environment. So even if the home is chaotic, if a child has somewhere to go during the workday where they are engaging in a positive way with other adults, other caregivers, other kids, that is also a really important tool to buffer against what might be happening in the home, but also setting kids up for success and setting the importance of learning early on in the engagement between caregivers and parents in support of the child. Similarly, preschool enrichment programs that specifically involve the family have also been shown to have lasting positive benefits on reducing early adversity and later outcomes. So again, lots of opportunity there through the early years of life. And then as we move into things like elementary school, middle, and high school, teaching social emotional learning skills, conflict resolution, healthy dating and relationships are all opportunities. And I think, again, this fits very much in where many substance use prevention programs play a role in thinking about not only resistance and social emotional learning for kids that might be offered in school, but also for family or parenting programs that can reinforce those messages, help parents navigate appropriate monitoring and engagement with their kids. And then specifically in the teenage years or preteens, thinking about safe dating and healthy relationships. Again, these programs have broad effects for reducing health risk behaviors, including substance use, and setting people up for success later in life. And I'll just mention here one example comes from the PROSPER program, which was a combined intervention randomized controlled trial for 28 public school districts. And they had both a sort of social emotional learning school-based intervention, which was a life skills training program. And then they had the Strengthening Families program, which was more of a family community-based intervention. And they examined a variety of substance use outcomes up to the age of 19. And what you can see here is across a variety of different substances or composite measures of substance use, there were substantial relative reduction in the rates of substance use at age 19 among individuals who are exposed to the intervention versus those who are not. There are other studies that look at this same intervention that show protective effects for things like prescription opioid misuse even into the early 20s, and spillover effects for peers of kids who were in the intervention also experienced some positive effects. So this is just one example of something that is called out specifically for ACEs prevention, but is also particularly beneficial for substance use prevention as well. And then there was a study that came out a few weeks ago that actually looked at multi-generational impacts of a universal preventive intervention. And this was, again, similar, sort of a multi-component intervention called Raising Healthy Children, which focused on teachers and how they work in the classroom, child social emotional skill development, and parent training. So you're addressing all three of those. And what they found is among the kids who were exposed, they had better outcomes on school misbehavior and achievement, lifetime violence, heavy alcohol use, mental health outcomes, employment, and socioeconomic outcomes. That was from the original study. This analysis actually looked at the kids of the kids who were exposed. So these kids were never, this second generation was never exposed to the intervention, but the question was, is there this carryover benefit to the next generation if we can instill positive effects in one generation? And what they found is that in that next generation of kids, there were better outcomes on child development functioning, behavior problems, academic skills and performance, and other risk behaviors, including substance use. So to me, as someone who thinks there is substantial opportunity for public health benefit from primary prevention, this really underscores that you can disrupt a multi-generational process and that you can even have benefits that carry over to the next generation by implementing prevention interventions among the prior generations. So to me, this was a very exciting recent research publication. I would certainly invite you to read the full article, but hopefully it also energizes coalitions to think about the importance of their work. If we're successful in instituting positive skills and substance use prevention among the generation we're working with now, we may be able to reduce the likelihood that that next generation is going to engage in those behaviors. Connecting youth to caring adults and activities is the next area in our prevention resource book. And this specifically focuses on mentoring and after-school programs. So again, the idea that even a single caring adult who is consistent, who shows up, and who can provide nurturing and sort of sense of safety and stability can really blunt the effects of even a quite chaotic home. And so if you think about kids who have experienced ACEs early on in life, that coach or that after-school mentor or the after-school program that provides them with structure and stability can help mitigate future harms from that earlier exposure or help to blunt the effects. So from a mentoring perspective, Big Brothers, Big Sisters is quite a well-known mentoring program. There are many others in communities that exist. After-school programs like the Boys and Girls Club, YMCA. There are specific tested programs like After School Matters, which focuses on STEM and other activities. Have research to demonstrate the benefits and protective effects for youth who are exposed to those activities. So again, as you think from a coalition perspective, who's at your table? Where are there opportunities? You're probably already doing this, but may not have thought about it in the context of ACEs prevention, but certainly an opportunity as you go back and begin your work with your coalition or continue your work with your coalition. And the last area really gets more into the individual aspect of intervening to lessen immediate and long-term harms. This is really among people who have previously experienced ACEs. And there are a variety of different strategies or interventions here. Things like safe environment for every kid, which is an enhanced primary care, which is where you do conduct screening and sort of individual family screening to identify, are there social services or other treatments that individuals need to be connected with due to adversity in the home. Victim-centered services. So if you have been a victim of interpersonal violence or domestic violence, having services that are provided, social services, health services, other services have a protective effect, not only for the individual who has experienced violence, but also for kids that might be in the home. There are specific trauma-informed treatments for people who have experienced various forms of ACEs or trauma. Trauma-focused cognitive behavioral therapy can be done, and it really focuses on how prior trauma can continue to play out and what are skills that individuals can utilize to reduce those impacts over time. There are sort of cognitive behavioral approaches within the school environment to address trauma that could be individual or at a broader classroom or even school or community environment. And then things like multisystemic therapy, which are really child-family therapy approaches to address trauma among adolescents and hopefully to prevent future harms. And then, of course, in the substance use space, supportive policies that enable family-centered treatment for substance use disorders, recognizing that, if you have kids at home and you're going to treatment somewhere, thinking about your kids and worrying about are they being taken care of certainly detracts from your ability to engage optimally in treatment, but also recognizing that substance use doesn't just impact the individual, it impacts the family. And there are services and treatments and other aspects of healing together that are important. And we know research shows that when we can engage in that way, outcomes are better. And here I just wanted to sort of lay out the strategies within our ACEs prevention resource and note that there are many parallels with the 7 strategies that coalitions are implementing. And they go from broader policies and looking at changing the environment to campaign and messaging and providing information, enhancing skills among youth, changing consequences, enhancing access, reducing barriers, and sort of changing the physical environment. And so there is a nice synergy between the evidence base for ACEs prevention and the work that coalitions are doing. And in the interest of time, because I do want to have the opportunity to take some questions, I'll just note that we are investing in community-wide projects at CDC to advance ACEs prevention. We are working with 5 local health departments in our Resilience Catalyst project, which focuses on really leveraging the health officer, the health department, as a way to bring the community together to address ACEs. We also fund 7 states through our Essentials for Childhood program, which really focuses on child abuse and neglect or child maltreatment, but calls out many of the prevention interventions for ACEs. We've also provided some funding to specifically look at the connection between this work for Essentials for Childhood and opioid misuse prevention. And you can see here the states that we are funding there. And then I'm most excited to say that we will soon be funding a small number of states specifically for a new program on ACEs prevention called Preventing Adverse Childhood Experiences Data to Action, where we will be taking a comprehensive approach to ACEs prevention to improve surveillance in our understanding of ACEs, where to target prevention opportunities and to evaluate and understand what's going on, to implement the variety of strategies that I've talked about today from our ACEs prevention toolkit, as well as using that data to really drive prevention. So I think across this program, across our Essentials for Childhood and our local health departments, if you are leading a coalition in those jurisdictions, that is another group of folks to really think about engaging with, because I think there's a real opportunity to leverage the great work that coalitions are doing and ensure that we are working together to advance prevention and improve the outcomes for youth. I'll also mention that we have a number of resources on the CDC website, particularly the Veto Violence webpage around ACEs. There are various training modules if you want to know more information or want to conduct a training for your coalition or for your community. There are videos and other training materials that are free to use and by the public. So please take advantage of those. And we also have a variety of technical packages in our violence prevention space that, again, like our overall ACEs prevention package, really provide the roadmap for reducing and preventing violence in the particular outcomes that you see here. And as with the coalition model, public health is not going to solve ACEs by itself. It really takes a whole of community approach. And again, I think that's why there's such great synergy between how we approach ACEs prevention and how coalitions are approaching substance use prevention as well. So thank you very much. Now turn it over to questions before we go to the break.
Dr. Jones, can you see the submitted questions below the video?
Let me try to pull that back up. I cannot.
Okay, I'll go ahead, and we have quite a few. If he does not get a chance to get to all of them, Dr. Jones, I can give you their emails and their questions, and you can maybe answer them directly if possible.
Sure.
So one of the first ones, does ACEs stop at age 17, or can items prior to full brain development affect in the same manner?
So we define ACEs up to the age of 18, but certainly the manifestations of prior trauma continue to play out. And certainly because we know that the brain is developing, in particular sort of executive functioning aspects of the brain are developing into the mid-20s, trauma that's experienced during that time certainly could have an impact on risk and risk behavior. So, it's not like somebody was 17 years old, 17 years, 364 days, and then, they go to 18 and those harms stop. There's only a spectrum there. As you see sort of the spectrum of brain development and plasticity of the brain, we know that does continue throughout the lifespan.
Okay, perfect. Next question. How much impact do you believe protective factors have on combating against ACEs? So for example, even if a person has 2 or more ACEs, if they have several protective factors as well, do you think that is where resiliency comes in?
Yeah, I think it's a really great question and a really important area as we think about prevention, not only in reducing risk factors, but also strengthening protective factors. And there is a movement in research. I think it's less well developed as our understanding of ACEs, but sort of protective childhood experiences. And so we know that even in a very chaotic environment where there might be violence in the home or substance use in the home, or food insecurity, housing insecurity, having a safe, stable, nurturing relationship in some other context of their life can have a blunting or protective effect. And so I think those are incredibly important. I think it's a very active area of research to really understand the interplay and to appreciate that one-time exposure to a traumatic event will play out differently for individuals versus someone who is repeatedly exposed to something. So there is also sort of the frequency and intensity of adverse childhood experiences that also shape the impacts on the structure and function of the brain and future health outcomes. That is a really challenging area of research. It's an area of research at CDC that we are trying to engage more in to understand sort of the spectrum of frequency, intensity, and interplay between multiple adverse childhood experiences, and how does that impact what we might do from a prevention or treatment standpoint.
All right, thank you. There was some questions about systemic racism, and was there a study carried out that systemic racism is an ACE?
So we know that it definitely contributes. And again, it's sort of expanding beyond. So the original ACEs study focused solely on those 8 specific ACEs that I mentioned. But as we appreciate sort of multi-generational impacts of poverty, lack of opportunity, systemic racism, all of those things are sort of in the environment, which is why we sort of like that schematic of the pair of ACEs, that it is not just these 8 things that have been put in place, but that there are these underlying context. And we definitely see consistently in the literature that populations of color, in particular African American populations, have a disproportionate burden of ACEs. And no doubt things like systemic racism, structural racism, those types of things are contributing and perpetuating, exacerbating those issues among populations of color.
Okay. Next question. Does the CDC have a position on the impact of intergenerational trauma in regards to racism and how this can be addressed in policy?
Yeah, I think it's somewhat similar to what I just shared, in that as we're thinking about policy and appreciating that there are these contextual factors, like institutional racism, systemic racism, that are contributing and perpetuating ACEs, in particular among certain populations, we do have to think about what is the equity in the policies that are being implemented. So if we have, paid family leave policies or family-friendly policies in a community, how is that distributed? Who is the benefit of that policy and who is not the benefit of that policy? If we make investments in early childhood, early Head Start, pre-K, those types of things, we know they provide a benefit, but how is that benefit distributed among a community? So I think that's where the lens of inequities or racial disparities, racial justice has to come into play. And I think especially in the current context in which we're in, that seat at the table has to be occupied as people are thinking about what are the policies, programs, and practices that we need to implement in our community.
Okay. This one is a little longer. So you said some children have diminished social reward. So with these kids, a teacher might not be able to encourage a certain outcome by giving them an incentive. Yet, these are often kids whose reward system in the brain might be primed for substance abuse. Why would a child be less influenced by a social reward? And do their brains only respond to the intensity of substances as a reward?
So again, this is a complex area of brain science, but I think it's sort of the reason that substances might be more rewarding or more reinforcing is that you get that large dopamine spike or response from using substances. And that if you have sort of the diminished reward where a kid who hasn't experienced ACEs might get a little dopamine hit from a teacher providing positive feedback, a kid who's experienced ACEs, they've made the way their brain works and the way it distributes and releases dopamine may be blunted. And so substances are rewarding because they overcome that threshold for feeling euphoria. And so that's why you might gravitate to high-risk behaviors, including substance use, because it is rewarding. And if you are prone to having sort of a diminished reward, you're getting a higher spike in dopamine. It's very complex, but hopefully that provides a little bit of insight.
All right. I want to just ask one more question to wrap this up. Could you address how to nourish resilience for children who have already experienced ACEs in more under-resourced or higher trauma communities? And how can understanding ACEs help prevention coalitions support the work of the recovery community?
Yeah, I mean, I think that it is definitely not a approach or single intervention is going to address those issues. Certainly for kids who have experienced ACEs, the first step is, are they continuing to experience ACEs? Does their environment need to change in order to remove them from a situation where they are continuing to experience ACEs? That's a first step. And then a second step is, if they've experienced ACEs, then thinking about what are the strategies to help mitigate those harms. So one, that could be safe, stable, nurturing relationships, mentorship, caring adults, a more stable environment, but also things like trauma-focused cognitive behavioral therapy or multisystemic therapy, which we know can help mitigate the impacts of trauma. So I think there are both things at the family and community level that are in our technical resource package, as well as things at the individual level that can help sort of mitigate the impacts of ACEs. As far as doing that in underserved communities, again, I think it gets to the question of equity and where are we deploying these and why is ACEs prevention important and why is data important? Well, you need to understand who is impacted in your population. And if you see that the populations that are most heavily impacted are in the underserved communities, which is likely the case in many communities, then as a coalition and as a community, we have to think about what's the distribution of benefit of policies and how do we deploy it out to the disproportionately burdened population. So I think it is really a confluence of data, awareness, and sort of individual and societal level strategies to more holistically address those impacts.
Okay, thank you so much. There are still a couple other questions, but I'll send those your way. And that's about it. We'll go on break and everyone will come back around 12 Eastern Standard Time with our second half of the presentation.
Thanks very much.
Okay, wonderful. So I can get us started then. I'm Brian King with the Centers for Disease Control and Prevention, and I'm going to be our leadoff speaker today, in addition to Grant Baldwin, who's my colleague at CDC. And we're going to shift gears a little bit for the second portion of today's session and talk more about the broader issue of vaping in the United States. And so I'm going to kick us off with a discussion regarding the broader landscape of vaping in the United States and the historical context, including where we are in terms of patterns of use. And that's going to tee us up for a more nuanced conversation from Dr. Baldwin around EVALI, or e-cigarette or vaping product use-associated lung injury that this country experienced towards the end of 2019. So without further ado, I'm going to share my screen and we'll get us going. Okay. So in terms of the background on the issue of e-cigarettes, the reason that this is so important is because there was a lot happening in the United States that ultimately set the stage for various things that ultimately facilitated or fueled the EVALI outbreak in the United States, and that included the surge in e-cigarette use. But before e-cigarettes entered the marketplace, we were actually making a lot of great progress in tobacco control in the United States. Cigarette smoking was going down for many years. It's been going down since the 1960s among adults, and then among youth, cigarette smoking has been going down since the late 1990s. And that was because of the Master Settlement Agreement in 1998 between the state's attorney general and the tobacco industry, where the industry stopped advertising in certain areas, and Joe Camel went away. And as a result, we started to see continued declines in cigarette smoking, which is one of the most greatest public health achievements of the past half century in this country. But on balance, the tobacco product landscape continues to evolve. And particularly when it comes to kids, we don't want to be playing this game of public health whack-a-mole, where we allow certain products to go up and certain products to go down. And that's basically what we've seen as the tobacco product landscape has evolved. And combustible products like cigarettes are going down, but e-cigarette use has increased. And we haven't seen just an evolution of tobacco products in general, but we've also seen an evolution of e-cigarette products. They first hit the market in 2007 in the United States, and now we're dealing with the great grandbabies of the e-cigarettes. They've evolved from first generation devices that were the same size and shape as regular cigarettes. And then the second generation came along, and these were refillable. So you recharge the device and put in the cartridge flavor or nicotine concentration of your preference. And then third generation came along, and these were products that are sometimes called tanks or mods. And these devices allow the user the most latitude to modify not only what's in it in terms of ingredients. You could put nicotine liquid, you could put THC containing liquid, but you could also modify the voltage. And when you increase the voltage, that can increase the heat and potentially harmful things. And then in 2015, something happened. A fourth generation product came, which we call the pod mod. And the reason we call it that is because they use a pod. And so it's a cartridge similar to the second generation, but that little pod contains the liquid. And so one of the most notable is Juul, which I'm sure all of you have probably heard. But there's also products that don't resemble USB flash drives like Juul, including a Sworn, which is that example on the far right. And these products are unique in that they allow the user to not only just buy a pre-filled cartridge, but to refill it with any a liquid of their preference. Again, that opened the door for the use of different substances in these devices besides just the traditional nicotine that we were seeing for many years. So this is market sale in the United States, a market share of retail sales of e-cigarettes in the United States back to 2013. And you can see that's a really volatile environment. But the line you want to focus on is that dotted black line, which was sales of Juul. So you can see that when they entered the market in 2015, they were not the primary game in town. But by the end of 2017, they had 30% of the market share. And by the end of 2019, they had 75% of the market share. So we started to see this shift towards these pod mod cartridge-based devices that could accommodate not only nicotine, but also other substances like THC. And so this is sales. So we don't know who's buying it, but it's no surprise that we saw mirrors in increases of these products among youth. And so these data are from the National Youth Tobacco Survey, which CDC collects every year, and it's a school-based survey. And the red line is e-cigarettes. All the other products are other tobacco products. And so you can see as everything else was either going down or staying the same, e-cigarette use was going up. And we saw some great progress in 2016 in terms of a decline in e-cigarette use among kids. And that was primarily because we started to implement policies that we know work to effectively reduce youth access restrictions, including e-cigarettes and smoke-free policies. So you couldn't use them in public environments, taxing the product so that it was less incentive for young people to buy them. But then something changed. In 2017, we saw a plateau and then ultimately an increase. And what was that? That was the introduction of these more novel products, those fourth generation products like Juul, which they weren't only just very sleek in design and could be easily concealed, but they also contained a new form of nicotine salts that I'll talk about in a bit. And also they could be used to accommodate other substances, including THC. So in contrast to youth, though, we were seeing a marked decline actually among adults in comparison to youth. So the youth estimates were going up to the point where we had 27.5% of kids using e-cigarettes in 2019. And during the same period, we had about 3% of adults. And so there was a slight uptick in 2018, primarily driven by young adults, that 18 to 24 demographic. But you can see that the burden of e-cigarette use in this country is primarily among young people. And that's why we're so concerned, because this is a population for which there's no redeeming aspects of these products, which contain a variety of different ingredients, which we'll discuss in a bit. So people frequently ask me, well, why did e-cigarette use go up in this country? And I say, I like to sum it up like this. The advertising will lead a horse to water, the flavors will get him to drink, and the nicotine will keep him coming back for more. That's the trifecta of factors that have created this environment of pronounced youth use of these products. We know that about 70% of U.S. youth report seeing advertisements for e-cigarettes, including on social media. And we know that about 70% of kids who use these products report using flavored varieties, and flavors are among the most common reason they report. And we also know that they typically have contained nicotine, which is not only highly addictive, but can also harm the developing adolescent brain, which continues to develop into young adulthood. But it's not only that there's nicotine, but there's higher levels of nicotine. And so the industry has evolved to include a new type that makes it easier to go down. And so most e-cigarettes in the past have used what we call free-base nicotine. And so think back to your high school chemistry class. Remember the litmus test where something that was very acidic was very red and something that was very alkaline was very blue. So most e-cigarettes in the past have used free-base nicotine, which is very blue. It's very alkaline. So that means it's also very volatile. And so you can't really use very high levels because it wouldn't be palatable to the user, including kids. And so what did Juul do with the invention of their product and their patent in 2015? They lowered the acidity. And so they made it more acidic. And by doing that, you created nicotine salts. And by doing that, you can allow higher levels of nicotine to go down a lot easier. And so it's also no surprise that not only are we seeing more kids use e-cigarettes, but among the ones who are using them, they're using them more. And that's a sign of dependence and addiction. And we also know that kids are using other products and other substances in these products as well, and that includes THC, the primary psychoactive ingredient in marijuana. And so we set this stage where these electronic products were readily accessible to youth, and then we started to see them being used to accommodate other psychoactive substances, including about 15% of youth nationally, and well over 1 in 5 U.S. high school students who use e-cigarettes report using THC in these devices. And so there's a lot of discussion around e-cigarettes. Are they public health promise or peril? And I like to summarize it in a way that has this balance in a scale in terms of, what are the net risks? What are the net benefits? When it comes to e-cigarettes, they're markedly safer than conventional cigarettes. They don't have nearly as many harmful chemicals, 7,000 chemicals and 70 carcinogens that are in cigarette smoke, but that doesn't mean they're safe, right? And so instead of having this discussion, around, the relative risk when it comes to kids, it's important to know that there is inherent risk to e-cigarettes, and they're not harmless water vapor. And so when we have any potential benefit among adult smokers, if they use them to quit completely, that can't come at the expense of the escalating rates of use that we're seeing in this country. And so in terms of available evidence on e-cigarettes and cessation, there's been a lot of comprehensive reviews, and the bottom line here is the science is still inconclusive. We know that some people anecdotally are quitting smoking using e-cigarettes, and that's a good thing. We want people to quit smoking, but the plural of anecdote isn't data, and we have to look at the available science. And the recent Surgeon General's report of 2020 summarized it very nicely in noting that the available evidence is inadequate to conclude that e-cigarettes in general increase smoking cessation. So we still need more science on that front in terms of efficacy for cessation. But again, we know that there's inherent risks that are shifting that balance in that scale, including concerns about gateway, initiation of regular cigarettes as a result of e-cigarettes, leading to relapse among current smokers or former smokers, diminishing the chances that a current smoker will use the product to quit, and also exposure to the aerosol, which we know is not risk-free. And there's also a lot of glamorization of these products as well. One of the initial endorsers was Jenny McCarthy, who would advertise these products, who I wouldn't exactly consider to be a pillar of public health advocacy. And then you also have poisonings and calls to poison control centers, which have escalated more recently as a result of EVALI. But we do know that we get about 4,000 calls per year for poison control centers for e-cigarettes preceding EVALI, and 50% of those were for kids under the age of 5. So there's definitely not only exposure through inhalation, but also dermal exposure and ingestion that can carry risks. And why is that? Because these products contain a variety of harmful and potentially harmful ingredients, including volatile organic compounds, ultrafine particles that can be inhaled deep into the lungs, heavy metals, cancer-causing chemicals like acrolein, but also the flavorings. And then, of course, we also know that they can be used to accommodate other substances, including nicotine and THC, which are detrimental to the developing adolescent brain. So that kind of set the stage for what we saw with EVALI that hit in the summer of 2019 that we're now going to shift to. And you can see that there was a lot of dialogue around the EVALI cases that occurred, but it's important for us to remember what was happening before EVALI occurred in terms of the product landscape and the type of devices. And so we ultimately named this e-cigarette or vaping product use-associated lung injury, and Dr. Baldwin is going to discuss the pathway that we took in terms of CDC using evidence-based strategies, but you can see that it got a lot of attention, including in the media. And this is our Deputy Director of CDC, Ann Schuchat, testifying to U.S. Congress, including me on the right. I clearly did not have my Snickers bar that day. I looked a little perturbed, but very serious issue and something that CDC invested a considerable amount of time and resources to help identify. And so before I shift over to EVALI, I do want to make a clear distinction for folks, which you're going to hear a little bit more about later, and that the youth epidemic is very distinct from the EVALI outbreak. Although they were interrelated in terms of setting the stage for an environment where these products were more accessible and acceptable, it's different drivers. And so when it comes to the youth epidemic, we know, of course, it's primarily among people less than 18 years of age. Nicotine-containing products, particularly from formal sources, like traditional retailers, brick and mortar, convenience stores, gas stations. And it's caused by that trifecta of factors that I briefly mentioned. Remember, the advertising will lead the horse to water, the flavors will get him to drink, and the nicotine keeps him coming back for more. In contrast, EVALI, as you'll hear more about, was primarily young adults, 18 to 34 years of age. It was THC-containing products, although there was a minority of nicotine-containing products, and they were obtained from informal sources. And of course, we now know that it was strongly linked to vitamin E acetate, which was a diluent used in these products. So again, both critically important things, public health issues that are facing our nation, but different drivers. And ultimately, the interventions that we're going to use to address them are going to be different, given that varying etiology. And so before I turn it over to Dr. Baldwin, I'm just going to end with some contact information. I have a famous email, baking@cdc.gov. Put your favorite recipes or other questions on salmonella and cookie dough. But we also have a variety of resources at CDC on e-cigarettes more generally, including CDC facts on cdc.gov/e-cigarettes, the Surgeon General's report and advisory that were released in 2016 and 2018, as well as the Lung Injury Response website. And we're also on all forms of social media, including now Pinterest. So if that doesn't get you excited, I don't know what will, folks. So with that, I'm going to turn it over to my colleague, Dr. Baldwin, who's going to do a little deeper dive in terms of the EVALI investigation and the implications for public health. Dr. Baldwin, take it away.
Great, thank you so much. Let me see if I can share my screen. Okay. Can you all see my slides at this point?
Yes, we can.
Yes.
Great. Well, thanks so much for the opportunity to be here. I've been asked to really talk about the growth and the impact of cannabis vaping in America. And as you just heard from Dr. King, there's really been an unprecedented increase in the use of nicotine-containing e-cigarettes, especially among young people. At the same time, there's been an increasing number of U.S. states that have legalized cannabis, and there's been a shift, as I'll show later, in the public perception about the risk of THC. So increases in cannabis use among adults, especially young adults, is occurring against the backdrop of a growing abundance of THC and CBD type products, including vapes. And the recent outbreak of vaping-associated lung injuries spotlighted attention to all of this, and frankly, the broader and immediate and decisive public health actions that we need to take to protect public health. So let me start with the bottom line up front. In January, Drs. Kings, Jones, and I published a commentary in the New England Journal of Medicine. And as you just heard from Dr. King, I actually have the same slide at the end of my deck. You've heard about one of two distinct but related epidemics connected to vaping: nicotine-containing e-cigarettes. I'll be talking about the other, the recent outbreak of lung injuries and the continued surge in cannabis vaping use by young people, including, problematically, more frequent and more potent use. The youth cannabis vaping epidemic differs in some key ways that I'll unpack for you over the course of the next 20 minutes or so. So this map shows the growing number of Americans with access to medicinal and recreational cannabis or low THC and CBD products. To put this together, I simply went to the census webpage and pulled the latest state-level population numbers. They were available through July of 2018. And as you can see on this slide, 68% of the US population, or 224 million people, now live in a state with legal non-medical or medical cannabis, or both. And only 2% of Americans, those in Idaho, South Dakota, Kansas, and Nebraska, live in a state with no law at all at this point. I should also mention as a backdrop that there were over 25 million youth 12 to 17 years old in the US in 2020. So how are cannabis use patterns changing in the US? This is data from a survey that I suspect you're all very familiar with, the National Survey on Drug Use and Health. As most of you know, it's an annual household survey. It began a number of years ago in 1971, and it provides up-to-date information on drug use in the US and all 50 states. It surveys non-institutionalized US civilians 12 and older, and in 2018, there were almost 68,000 surveys completed. So on this slide, I show that marijuana is the most used illicit drug in the US for persons aged 12 and older in the past year. And this corresponds to 15.9% of Americans, or 43.5 million people who used in the past year. This represents a 45% increase in marijuana users, or over 13 million more people from 2002. So here's past year marijuana use trends over time broken down by age. So the recent increase is being driven by the increase in past year use for 18 to 25-year-olds and those aged 26 and older, especially those 26 and older. And the point prevalence for 18 to 25-year-olds increased from 27.8 to 34.8%. So over 1 in 3 people aged 18 to 25 reported past year use. And use among those 26 and older in the last decade almost doubled from 7 to 13.3%. Use among those 12 to 17 years old is relatively flat, especially in recent years, and has gone down slightly in the last 10 from 13.1 to 12.5%. That's maybe a little bit of good news, but unfortunately that masks the form or type of use, which as you will see, poses unique problems in and of itself. So what about the trends in new marijuana initiates over time? So just like we observed with past year marijuana use, the increase in use of new initiates is driven by Americans 18 and older, especially those aged 26 and older in the last decade. There were 1.3 million youth aged 12 to 17 that initiated marijuana use in 2018, or about, and this is staggering to me, 3,700 youth per day. The number of new initiates among youth has again remained relatively stable over the last 15 years. And this is a graph from the 2018 UN Office of Drug Control World Drug Report, but it's showing NSDA data from 2006 to 2018. And it's striking, I think, because of what it conveys, even though it's not youth specific. The story here is really about more frequent use and how that is in fact going up. So as you can see, there were 38 and 24 million cannabis users in the past year and month, respectively, in 2016 in the US. And there was approximately 10 million people that were daily users. Those numbers represent a 48% increase in annual use, a 61% increase in monthly use, and a 96% increase in daily use from 2006. So the point prevalence, and this is striking, for daily use nearly doubled. So why is that a problem? Well, we know that people who use marijuana more than 200 days per year are at an even greater odds for adverse outcome, like developing a substance use disorder for prescription opioids, heroin, cocaine, and other drugs. So here I want to call attention to the self-reported THC vaping, and Dr. King mentioned some of this among middle and high school age students. So Monitoring the Future is an ongoing long-term epi-study that surveys trends in behaviors, attitudes, and values in legal and illicit drug use among American adolescents and young adults. It began actually right around the time that NSDA did in 1975 and is funded by the National Institute on Drug Abuse, but it's instituted by the University of Michigan and their Institute for Social Research. The sample is drawn from 43,000 youth in almost 400 public and private schools across the country. A total of 1 in 7, or 14%, of U.S. high school seniors report past month THC use in 2019. That's almost double what it was in 2018. And this is the second largest jump for any drug in the history of the survey. The only increase that was higher was actually the increase in nicotine vaping between 2017 and 2018. So this is a small study of first-time or infrequent users, and it showed that researchers showed that marijuana inhaled through a vape device produces a more powerful high, and often, as I'll show you, with more harmful side effects than the smoked version. So participants smoked and vaped marijuana at 3 different THC doses, 0, 10, and 25 milligrams, with, of course, 0 serving as the control in what was a blinded study. Participants completed the drug effects questionnaire, they're rating their self-reported drug effects out of a score ultimately that sort of compiled up to 100 shortly after smoking, and for each hour up to 8 hours, as you see on the graph, after their initial after they initially smoked. The survey assessed overall drug effect, so feeling sick, anxious, hungry, sleepy, and restless, and experiencing a heart racing, dry mouth, and dry eyes, memory impairment, as well as coughing. And the results are shown in the graphs on the slide. Overall, at the same level of THC, vaping led to higher blood concentrations of the chemical than smoking, as well as higher levels of cognitive and psychomotor impairment, and a higher incidence of adverse effects such as vomiting, anxiety, hallucinations, and feelings of paranoia. Researchers speculated that the stronger effects observed with vaping are because none of the material is lost to combustion. In short, there's not an equivalence between vaping and smoking marijuana at the same amount of THC. And given that adolescents are more likely to vape than smoke, this is problematic for a whole host of reasons. This is data from Washington State. So researchers there examined retail sales data from Washington's legal marketplace between July 2014 and September 2016. And the study had a remarkable number of sales, so over 44 plus million items being sold. At the time, traditional cannabis flowers still accounted for over 2/3 of sales, but market share for extracts increased almost 150% and comprised 1 in 5 sales at the time, and that's gone up markedly, and I'll show data in a second about that. So the graph on the left in green shows the THC potency range of these products. Of note, the average THC level for cannabis extract is more than triple that for cannabis flowers, so 68.7% compared to 20.6%, as you see on the slide. The graph on the right makes the connection between increased potency and more frequent use and more adverse health outcomes. It was just published not too long ago and uses data from a long-term health study in the UK that recruited more than 14,000 pregnant women and their babies born in and around a town in the UK called Bristol in the early 1990s. The research looked at data collected for over 1,000 participants aged 24 years old who had reported using cannabis in the previous year, of which about 13% reported use of high-potency cannabis. They found that people who used high-potency cannabis were more than 4 times as likely to report weekly or daily use and report symptoms of cannabis misuse, and almost twice as likely to report anxiety disorder. And given the longitudinal design of the study, they were able to account for the effect that people's earlier adolescent mental health symptoms may have had on the relationship. So they were, in fact, able to control for that. So the key takeaway is that limiting the availability of high-potency cannabis may reduce the number of individuals who develop cannabis use disorder, prevent cannabis use escalating to a regular behavior, and reducing the impacts of cannabis on somebody's mental health. So as use has gone up, perceived risk has actually gone down, both relative to itself and benchmarked to other drugs. This graph shows that less than 1/3 of Americans 12 and older, or 32%, perceived great risk from smoking marijuana once or twice a week in 2017. This number is significantly lower than those that perceive risk from once or twice a week heroin use at 94%, cocaine use at 87%, and even binge drinking once or twice a week at 45%. This number has also gone down over time. So in 2002, over 50% of Americans 12 and older perceived great risk from once or twice a week marijuana use. And earlier research has shown that as perceived risk goes down, use goes up. And unfortunately, the current trends affirm that again. So what about the cannabis market? It is growing exponentially. So in 6 years, from 2017 to 2022, the U.S. market is projected to triple to be about $29 billion. Again, billion dollars. As shown here, cannabis consumers are also moving away from simply smoking the product. During the same 5-year period, the U.S. concentrates market, of course driven by vaping, is expected to increase 5-fold to $10.5 billion. And like nicotine-containing e-cigarettes, cannabis concentrates are also more discreet, more convenient, and as I mentioned a few slides ago, more potent than any other type of cannabis product. So the data on this slide shows why age at first use matters so much. The table, and I apologize if it's a little hard to read on your screen, shows the 12-month prevalence of having a cannabis use disorder that meets a DSM-4 criteria, and that it increases over time depending upon age at first use. So youth at the highest risk for eventually developing a use disorder. Excuse me. As you can see, 1 in 5 youth aged 12 to 17, or over 20%, have a cannabis use disorder who started using cannabis more than 3 years ago, and the risk increases with each passing year. And then the number drops a little bit if first use started later. So 1 in 10 young adults aged 18 to 25, or slightly more than 10%, have a cannabis use disorder who started cannabis use more than 3 years ago. Again, note the linear trend here, though. The longer you use, the greater the odds of developing a cannabis use disorder, with risk elevated quite quickly, especially among young users. So while conclusive evidence regarding the short and long-term effects, both harms and benefits of cannabis use, remains somewhat elusive, the 2017 report from the National Academies did note several consequences of cannabis use, especially long-term heavy use. Excuse me. Effects range from short-term problems with attention, memory, and learning to longer-term problems such as psychosis, anxiety, substance use disorder, depression, and an increased incidence of suicidal ideation and attempts. Developing brains, like you heard from Dr. Jones earlier, like those in adolescence, are especially susceptible to adverse effects from cannabis, and that's why it's so critical that more study is needed. The National Academies report specifically called for this, including the risks of THC vaping on vulnerable populations like youth, and more study on the beneficial and harmful effects of understudied products like concentrates. So now let's shift and talk very specifically about the other vaping-related epidemic, the recent outbreak of lung injuries. So CDC, FDA, state and local health departments, and public health and clinical partners began investigating a national outbreak of e-cigarette or vaping product lung injury, or as you heard from Dr. King earlier, EVALI, in August of 2019. It started with a cluster of cases in northern Illinois and southern Wisconsin, and staff from my division were some of the initial responders. Symptoms reported included cough, shortness of breath, chest pain, nausea, vomiting, abdominal pain or diarrhea, and fever, chills, or weight loss. At the time, a lung infection did not appear to be the cause of the symptoms because it wasn't responding to antibiotics. As additional states began to report cases and the first possible death occurred in Illinois, CDC recognized the need to stand up, at the time, its Emergency Operations Center, something that we're doing now, obviously, as well with the COVID-19 pandemic. Under this incident management structure, additional staff and resources could be quickly brought to bear. And so the activation stood up with the 4 goals listed on the slide. So over the course of the response, there was about 450 people at CDC who were directly involved in addressing the issue. The timeline on the right outlines some key milestones in our investigation, and this included developing a standardized case definition to better track cases, issuing clinical recommendations to inform patient care, publishing data about cases in CDC's Morbidity and Mortality Weekly Report, our MMWR, it's CDC's Sentinel publication, and sharing with the public and key partners everything we knew when we knew it. And finally, developing and implementing the laboratory methods that ultimately became so critical in helping us to solve the mystery. So as the outbreak evolved, data collected from states showed that EVALI patients were more likely to be male, under the age of 24, and use THC-containing products. There are a total of 26,668 hospitalized EVALI cases or deaths as of January 14th, and I have some updated data on a couple of slides from now. At the time, over 2/3 were male. The median age of patients was 24 years and ranged from 13 years old to 85 years old. 52% were under the age of 24. So over half of the EVALI patients were under the age of 24. And over 80% reported THC-containing product use, and 57% reported using nicotine-containing products. So here are the epi curves. The weekly number of hospital admissions for EVALI reported to CDC, the purple bar chart, peaked at 215 during the week of September 15th, 2019. And since then, the number of cases reported each week has continued its steady decline. We also developed a syndrome definition in the National Syndromic Surveillance Program, or what we call NSSP. And this system has near real-time data from up to 70% of the nation's emergency department visits. NSSP data shows that the number of possible EVALI-related ED visits rose sharply between August 11th and September 8th, 2019. And the weekly visit rate peaked at 116 per million ED visits during the week of September 8th, and then decreased steadily to 35 per million visits in early January. This remains, by the way, higher than the pre-outbreak rate of 23 per million in mid-August of 2019. So this map shows the distribution of cases across the country as of February 18th, 2020, the last time we published on it. EVALI cases have been reported to CDC from all 50 states, DC, and 2 U.S. territories, Puerto Rico and the U.S. Virgin Islands. Total of 68 people have died from EVALI in 29 states and the District of Columbia. And the asterisk denotes the states with the deaths. As you can see on the graphic, the most cases have occurred in the Midwest, Texas, and California. So as more data became available, it became increasingly clear to us that THC-containing vaping products, particularly from informal sources like friends, family, or an in-person or online dealer, were linked to most EVALI cases and frankly played a major role in the outbreak. The purple bar chart on the top shows the distribution by age, with informal sources being especially popular among 18 to 24-year-olds. And overall, 78% of EVALI cases with THC use obtained them from informal sources. And the blue bar chart on the bottom highlights the 152 different THC-containing product brands that were reported to us by EVALI patients. I should say that dank vapes, a class of largely counterfeit THC-containing products of unknown origin, was the most commonly reported product brand, but the data show that EVALI is not likely associated with a single THC-containing product brand. So on November 8th, we announced that we had made a breakthrough in finding a possible cause of EVALI. It was the first time that we detected a potential chemical of concern, in this case, vitamin E acetate, in biologic samples from patients with EVALI. While vitamin E acetates had been measured in product samples used by patients, these new data provided really direct evidence that it was vitamin E acetate at the primary site of injury within the lungs. Bronchoalveolar lavage fluid, or BAL fluid in short, is fluid collected from the lungs. And this data from a New England Journal of Medicine article is a follow-on to the initial finding that we published in November. We analyzed samples from 51 EVALI patients from 16 states and a comparison group of samples from 99 healthy people for vitamin E acetate, plant oils, medium-chain triglyceride oil, coconut oil, petroleum distillates, and diluent terpenes. As highlighted by the red box, vitamin E acetate was identified in BAA samples from 48 of the 51 EVALI patients, but not in the BAL fluid from anyone in the comparison group. And no other toxicants were found in BAL fluid from either group, except for coconut oil and some limonene in one EVALI patient each. So vitamin E acetate is an oily chemical additive or cutting agent found in some THC vaping liquids that is used to thicken or dilute them. It's found, vitamin E obviously is a vitamin found in many foods, including vegetable oils, cereals, meats, fruits, vegetables. It's also available as a dietary supplement and in many cosmetic products like skin creams. And it usually does not cause harm when ingested as a vitamin supplement or when it's applied to the skin. But one manufacturer sold a cutting-edge product called Honey Cut that mirrored the color and viscosity of THC oil and did not impact its flavor. It was 90% vitamin E acetate, and frankly, for them, it generated astronomical profits. On the next couple of slides, I'm going to show you CDC's current recommendations after the presentation, because I want to leave at least a few minutes for questions. You can go through them in detail. I'll mention just a few of them: that people should not use THC-containing e-cigarettes or vaping products, particularly from those informal sources like friends, family, or in-person or online dealers. Vitamin E acetate should not be added to any e-cigarette or vaping product. and people should not add any substance not intended by the manufacturer to products, including products purchased from retail establishments. If you choose to use e-cigarettes as an alternate to cigarettes, you should completely switch from cigarettes to e-cigarettes and not partake in any extended period of dual use of both products that ultimately may delay your efforts for smoking cessation. You should contact your healthcare provider if you need help quitting tobacco products, including e-cigarettes, especially if you have concerns about EVALI. E-cigarette or vaping products should never be used by youth, young adults, or women who are pregnant. Obviously, youth and young adults, a very strong interest to this audience. And adults who do not currently use tobacco products should not start using e-cigarette or vaping products. And then THC use has been, as I showed earlier, been associated with a wide range of health effects, particularly with that prolonged, frequent, and high potency use. And the best way to avoid potential harm is to not use THC-containing e-cigarette or vaping products. And persons engaged in ongoing cannabis use that leads to significant impairment or distress should seek evidence-based treatment by a healthcare provider. And I want to end actually with the same slide that Dr. King showed at the end of his deck. So the youth epidemic primarily affects adolescents less than 18 years old, is driven by the use of nicotine-containing products obtained mostly, as Dr. King mentioned, from formal sources such as illicit retailers, and has been caused by a multitude of factors, included his trifecta, if you will. And in contrast, EVALI primarily affects young adults 18 to 34. The population with the highest rate of marijuana use in the United States is driven by the use of THC-containing products from informal or illicit sources, and is linked to thickening agents or dilutants in product formulations, especially those found in illicit markets, and notably, as I mentioned a couple of slides ago, vitamin E acetate. But irrespective of the epidemic, the increased use in vaping among youth and young adults is unsafe, regardless of whether they are used to deliver nicotine or THC. Both marijuana and nicotine use can harm the developing adolescent brain, and starting to use these substances at a younger age also leads to higher risks for more problematic use later in life. So with that, let me stop there. I think that gives us a good bit of time for questions. I'm sure there must be some, and let's open up to that.
Can you guys see the questions submitted, or would you like me to go ahead and just read some of them out? We just have a couple of them right now.
Please read them out.
Okay, perfect. Just give me 1 second. Can you speak to the why it peaked in August and why it declined after that? What are some specific interventions that were done to not see the cases, considering marijuana use in vaping devices continue to be utilized? I assume the vitamin E acetate was being used prior to August and even after that, or were manufacturers banned from having that ingredient?
Well, there's no formal ban on it, but I think as word got out, we spent a lot of effort with public education and outreach to inform consumers about the risks associated with THC use, and I think that had a chilling effect on the marketplace, including the informal marketplace that ultimately had it removed. But Dr. King, I'm sure you have some thoughts. You were heavily involved in this.
Yeah, sure. I mean, I would agree with Dr. Baldwin on this, in that we had a pronounced public education effort where we started warning people about the inherent risks of these products. And so once we were able to refine our recommendations as more data came in, we could be more specific around our recommendations. And that included first the THC-containing products and finally the vitamin E. I think that there was ultimately some voluntary efforts as well within the individuals who are creating these products. Of course, if even in the illicit market, if you're doing something to your products that's killing your consumer base, it would behoove you to remove those from the market, right? And so it was multifactorial, but the primary driver here was really the public health community came out and used data to drive evidence-based recommendations that help not only find the cause, but also protect the American public from this health risk.
Okay. What can we do to help kids who are already addicted to vaping when there are very limited resources to help them since they are minors? For instance, adults have gum patches, but obviously that wouldn't be approved for them.
Yeah, so I can start on the nicotine front, and then I'll defer to Dr. Baldwin on the treatment for THC and marijuana. When it comes to nicotine, we don't have any FDA-approved medications for youth. It's only among adults, and even then, it's just for conventional cigarettes. And so we have 7 FDA-approved medications. And we also know that behavioral counseling is effective from a healthcare provider from adults. When it comes to youth, the only evidence we have right now is around prevention in terms of behavioral counseling, and so we know that it's a grade B rating with the U.S. Preventive Services Task Force, which is critical. And we also know that there's some added benefit of potential cessation when it comes to healthcare providers as well when it comes to youth. And so that's really a primary driver, is identifying the use in the clinical environment, and also parents, educators, teachers, others involved, youth influencers, also being able to not only identify the use of the products, but ensure that youth have access to these clinical resources. We're also seeing an emergence of novel strategies, including mobile and app-based approaches. The evaluation data is very limited, but they're looking promising. And so this makes sense, right? We know that youth communicate in different ways. And so reaching them with these types of interventions, including mobile-based app approaches, can be effective. The Truth Initiative has an app currently that is widely used among youth for the purposes of e-cigarette cessation. And we also are seeing a growing body of curricula in schools as well. So it's not going to be a one-size-fits-all, but I can't reinforce enough the importance of population-based prevention, right? And if you create an environment where the products are less accessible and less acceptable, you're going to help cultivate not only prevention, but also cessation. But when it comes to direct treatment for cessation, right now we don't have anything beyond clinical intervention and healthcare provider counseling, but there are a growing number of studies, and the FDA has had 2 workshops to look at the available science to develop some trials to look more specifically at potential medications and also other intervention efficacy.
And I would just add, I think there's within the THC space, there's an analog to everything that Dr. King just described. Obviously, connecting with your healthcare provider, getting up front with our prevention activities, prevention messaging is critically important. That's why the work of all the DFCs is so essential. But again, it would, if you develop a problematic use, there are evidence-based therapies available. Work with your doctor to be linked up with that, but then taking advantage of some of the other channels of communication that youth are using right now, that messaging that can be delivered to them is going to be critically important as well.
Let's see. The next question, is it true that EVALI and COVID-19 have similar symptoms, and does vaping increase a person's risk of complications with COVID-19?
So I can start. It's correct that there are some comparable signs and symptoms, which in terms of EVALI, it's called a diagnosis of exclusion. And so you have to exclude everything else out in order to isolate the specific causes of EVALI. And so in the middle of the EVALI outbreak, this actually occurred with the issue of influenza. We were going into flu season, and so it was important for us to be able to disentangle the two. And the same goes for COVID-19, and ensuring that we implement the appropriate types of tests to ensure that we can rule out other factors before we isolate it as being EVALI as the cause. Right now, it's very apparent that these are 2 very different things, though. We've isolated EVALI to primarily vitamin E acetate, and just the temporality and geography shows this is very distinct. But when it comes to the transection between the 2, there's a growing body of science showing that people who smoke cigarettes may be at increased risk for more severe disease from COVID-19. So once you get it, there could be more increased disease severity. But whether smoking cigarettes increases the risk of getting infected with the virus that causes COVID-19 is uncertain. And the same goes for e-cigarettes. We simply don't have enough data to know whether e-cigarette use increases the risk of infection or whether it results in more severe disease. But we're actively collecting data through a variety of mechanisms to analyze that with more rigor. But the bottom line is that we know that smoking obviously harms nearly every organ of the body, and people who are immunocompromised are at increased risk of more severe disease. And we continue to monitor the e-cigarette situation. But it is very clear that someone who would have a type of lung injury like EVALI would be expected to have an increased risk of COVID-19 just because you have that initial infection and initial compromising to the immune system.
Okay, thank you very much. Next question. How do we anticipate the vaping situation to change with recent changes in device availability? Have you seen any upticks in disposables like smoke sticks? And how will this change the FDA's pre-market tobacco application requirements going into effect in September?
So I learned long ago not to speak for other federal agencies, so I'm not going to speak for FDA's regulatory structure, but I will say that the e-cigarette landscape is very dynamic. We've got a lot of products entering into the market as a result of other exterior factors, including different regulations of these products at the national, state, and local level. So it's really important for us to monitor the impact of those policies so we can ensure that we are not leaving any type of product behind that's particularly prominent among youth. That being said, currently disposable e-cigarettes such as Puff Bar are illegally able to be sold in the United States, although FDA recently implemented its enforcement discretion for those products. And so we did see from the retail sales data an increase in disposable products within the past several months, about the half year, which could be reflective of the fact that those were the primary product that were available on the market, particularly related to flavors. But it's important to note that there are actions being taken at the national, state level. FDA recently issued a warning letter to the manufacturer of Puff Bars, and there's also considerable momentum at the state and local level to implement policies prohibiting all types of e-cigarettes, particularly those that contain flavors.
Thank you. Do you have any data supporting youth turning to combustible cigarettes who started nicotine and using vaping as a delivery system?
So there's about 24 studies internationally in the United States, the UK, and Canada that show that kids who use e-cigarettes are more likely to smoke cigarettes in the future. It's about an 8-fold increased risk. So does that mean that every kid who uses an e-cigarette is going to go on to smoke cigarettes? Absolutely not. But that's one more tool in our toolkit of concern, if you will, around the different factors that are driving youth cigarette smoking. So the evidence is not conclusive, but we now have about 24 longitudinal studies that are suggesting that. Dr. Baldwin might want to speak to the fact that this isn't the first time we've seen this kind of gateway effect when it comes to substance use. And so it shouldn't be surprising to us that a product that has so much nicotine is leading to potential gateway effect for another product. I don't know, Grant, if you wanted to touch on that a little further.
No, and I think right now we're in the midst of a polysubstance epidemic, and as we've seen the transition from on the opioid side from a prescription opioid problem now to the illicit marketplace, first heroin, now illicit fentanyl, I think there's a long history, a long pattern, if you will, of problematic drug use leading to polysubstance use across a wider variety of drugs. And so we've seen an epidemic of other drugs shift from almost exclusively prescription opioids to heroin, illicit fentanyl, and now the opioids are being mixed into cocaine and other psychostimulants, particularly methamphetamines. Over.
All right, next question. Is the CDC thinking of creating national quit lines for vaping?
So currently, CDC does not run quit lines. Those are actually run by respective states. There's a national quit line portal, and it currently covers all 50 U.S. states. And there's also some specialized quit lines, particularly for Hispanic-speaking individuals, and then also an Asian American quit line. And so there's increased capacity for that current quit line structure to accommodate behavioral counseling and other resources around vaping. And so if an individual, and particularly adults, want to quit the use of these products, they can call 1-800-QUIT-NOW, 1-800-QUIT-NOW, and they will triage them to their respective state quit line based on the phone number that they're calling from to get resources. When it comes to what's provided, it's free of charge. You can get behavioral counseling from a trained quit coach for a variety of tobacco products, including e-cigarettes. And in some cases, you can also qualify for free nicotine replacement therapy, such as the patch and the nicotine gum, but that's for conventional products, not e-cigarettes. If someone, an adult, wants to use nicotine replacement therapy to quit e-cigarettes, that's a decision that should be made with their healthcare provider, including more nuanced discussions about the potential implications, particularly for young people.
All right, thank you very much. Is EVALI similar to popcorn lung?
Oh, so no. So popcorn lung is bronchiolitis obliterans. And so the reason it's called popcorn lungs is because years ago we were finding all of this workplace exposure to a very severe respiratory illness that was being caused. And they ultimately linked it to the flavoring diacetyl, which is used in popcorn flavoring. And so there was outbreaks in occupational environments years ago. And that's a distinct bronchiolitis obliterans is a distinct respiratory outcome compared to e-cigarette or vaping product use associated lung injury. There are some commonalities in terms of symptoms, but these are two distinct clinical outcomes and driven by different factors as well. It's not the same cause. For popcorn lung, it's diacetyl, and for EVALI, it's primarily vitamin E acetate.
Mm-hmm. All right. We have someone asking about resources on your site for how to make this data accessible and relatable to teens and young adults.
To talk a little bit more about the question, that they would like more youth-centered materials on our website associated with EVALI. I'm confident, and Brian can speak to them, the materials on the Office of Smoking and Health site, I think are already very youth-centered.
Yeah, absolutely. So if you go to cdc.gov/e-cigarettes, there's a variety of materials focused on e-cigarettes more broadly, including the fact sheets, infographics, social media content. There's a lot of great materials for adults as well, including parent-child discussion cards with ways to kickstart discussions around these risks. And we also have some presentations as well that are youth-centric, so that public health professionals, such as many of those on the line, can just download that PowerPoint and they can use that in terms of educating the youth in schools. And so I'd encourage you to go to cdc.gov/e-cigarettes. We do have some materials as well on EVALI, but I will reinforce that about 15% of EVALI cases were youth. And so in terms of, the broader e-cigarette dynamic and that youth epidemic, it's going to be those broader e-cigarette messaging points that are going to be most useful. So go to cdc.gov/e-cigarettes.
And I'll just add, we just stood up a cannabis strategy unit within my division. Education and outreach is one of the key pillars of that work. But it's a relatively small unit right now with a couple of 3 staff, and so we're in the process of building out that body of work. Obviously, given where we are with cannabis use in this country, it's a major priority for me moving forward, and look forward to growing that work, including on education and outreach to a wide variety of stakeholders, including importantly youth.
All right, I think we just have one more question. It's a little related. So nicotine pouches are becoming popular again, such as Velo, Snus, and Zyn. Any suggestions for prevention without introducing youth to a new nicotine product?
Yeah, sure. So the bottom line here is, if it looks like a duck and quacks like a duck, it is a duck. So reinvent the wheel here. We just need to grease that squeaky wheel, if you will, to modernize our interventions to address the diversity of products. So it's those same population-based interventions that we know work: increasing price, incorporating smoke-free policies, and even tobacco-free policies that don't allow their use, mass reach health communication campaigns that warn people about the risks, youth access restrictions, and also cessation services for those using the product. So we don't need to reinvent the wheel here. We just need to ensure that we incorporate these new types of tobacco products, including products such as nicotine pouches, into our existing evidence-based messaging and also into our research. We know that we can capture use because what gets measured gets done. And so we've got to measure the use and then also implement strategies to prevent and reduce use, particularly among kids.
All right. Thank you so much for answering all those questions. It sounds like everyone really enjoyed your presentation based off of the chat box. They thought it was very valuable information to take forward to their communities. So with that, we are pretty much done. Thank you so much for speaking today.
Great. Thanks so much.
Yeah, of course. And whoever's still on the line, please make sure you do your evaluations. No, we'd love to hear back from you guys.